myself Dr. Priyanka and I'm one of your mentors for study MRCPI. So we are back again with the OMR series, which discusses very important stations, the exam oriented stations. So today we'll be discussing an important structured discussion task on molar pregnancy. So do like, share, and subscribe Study Medic channel to get the recent updates on the recently added videos. So always do remember that don't wait for the opportunity, create it. So this is a structured discussion task where I will be the candidate and Dr. Soumya will be my examiner.
Hi, Priya. Just
Hello.
a second. Let me keep a timer so that we would be able to make it time-based. Okay, darling. You can start if you have gone through the scenario. Please start.
Hello, I'm Priyanka. I'm one of the exam candidates today. I have read the scenario and I'm ready for the discussion.
Okay, what information you want to gather from her?
So she's 26 years old with 9 weeks of amenorrhea and with spotting and also with excessive vomiting. So first here I would like to ask her about her history of her complaints. So since when is she having vomiting and how severe it is? Why I would like to classify according to the puke score. And is she able to take liquids or not able to take the liquids? And regarding her spotting also, so how it is it a spotting or yeah, is there any passage of clots? So that I would like to elicit. Further that, then I would like to ask about her the obstetric history, if there is any especially history of any previous twin pregnancies or molar pregnancies which can cause excessive vomiting. Then her medical history also is very important because some medical conditions like any gastrointestinal or renal problems can also cause hyperemesis. Further that I would like to ask any past history and any family history, especially of any twin pregnancies, then her any allergies, if there are any, I want to rule out. And she has come with spotting, so also I would like to ask if she had received one cervical invitation at 25 years and has she done that and is it normal? Then I would like to elicit her BMI and also the blood group and RH group. And if she has any reservations for blood transfusion, that is very important because if it's a molar pregnancy and it will be a surgical management. So before that, I would like to elicit that. Then further, after the BMI, any risk of any VT, I would like to rule out in this patient. Yeah.
Okay. So actually, she has been omitting a lot and it is affecting her quality of life. Nothing she is able to take in, and the spotting is on and off. And this is her actually the first pregnancy. Okay. So you've already told me a couple of differential diagnoses, but when a patient like this comes in, what are the differential diagnoses you think of?
Yes. So she's with excessive hyperemesis. So for that, there can be the most common differential diagnosis can be hyperemesis gravidarum. Also, hyperemesis is also seen in multiple pregnancies due to high HCG levels and also in molar pregnancies. So due to high HCG levels, so that can be the differential diagnosis. And regarding spotting, so it can be due to a threatened miscarriage or an even an ectopic pregnancy also.
Okay. So to come to a conclusion, what are the different investigations you would want to order and also for her management and justify them? Why do you want to do them?
Yes. So she has come with spotting and vomiting. So first, I would like to do the basic investigations in the form of complete blood count, urine analysis, complete blood count to look her hemoglobin levels, and the urine analysis to rule out any UTIs that can be even the cause of urinary problems that can be the cause of excessive vomiting. Uh, then I would like to do the liver function test, the renal function test. Sometimes that can be the also reason for excessive vomiting. Her blood group and RH typing in case if it's a molar pregnancy. So if it is RH negative, to give the anti-D if she's non-sensitized, and serum urea and electrolytes to categorize the severity of her vomiting. I would like to do that. Also in imaging, I would like to do an ultrasound, first of all, to look for the location of the pregnancy, whether it is intrauterine or and to rule out the differentials, that is the ectopic, and also to rule out any molar or multiple pregnancy in these cases. And HCG levels, so because they will be very high in case of molar and multiple pregnancy.
Okay. So what is the thing like they have done an ultrasound. So if you move to the next slide, you can see the image. Tell me what's your diagnosis looking at this and how do you want to manage?
Yeah. So here in this ultrasound, this is a transabdominal ultrasound, which shows there is a all over the inside the uterine cavity there is presence of trophoblast without any fetal part seen, which suggests of the complete molar pregnancy. The specific characteristic is it is called as a snowstorm appearance, which is seen in complete mole.
Okay. How would you manage?
Yeah. So her management here, first I would like to admit this patient, and as it is a complete mole, and here I have to tackle two things. First is her hyperemesis. So for that I will start her on, depending upon the severity, I will start her on IV fluids and also the antiemetics. Then coming to her molar pregnancy. So here the management will be in the form of suction evacuation under real-time ultrasound guidance. But before that, I would, as this is the case of a breaking bad news, so I would sensitively uh, break the bad news and especially tell her if she wants to call her any relatives. And after breaking the bad news, we'll explain her what condition is she having. So for molar pregnancy, it will be suction evacuation under real-time ultrasound guidance under supervision of a senior consultant. And before that, I would like to make sure her bloods are, her hemoglobin levels and all are optimized, because there is increased risk of bleeding in case of a suction evacuation of molar pregnancy. And regarding cervical priming, so the recommendation is that it can be done immediately before the procedure. And regarding oxytocin, so usually it is routinely not recommended, but in because of theoretical risk of embolization. But in case if there is a severe life-threatening hemorrhage, then it can be used under consultant decision. So that will be the management. And the follow-up, for as this is a complete mole, so it will be the HCG levels after the suction evacuation will be checked weekly until three values are 3 weeks, until three values are showing normal HCG levels. After that, the follow-up will be that if the HCG levels come to normal within 56 days, that is 8 weeks of the suction evacuation, the follow-up will be for 6 months from the date of evacuation. If they come to normal, if they take time to come to normal for after more than 56 days, that is 8 weeks. So the follow-up will be from 6 months from the date of normalization of the HCG. Also, I would like to make sure after the follow-up, like during the follow-up, I would like to prescribe her contraception, and I will suggest her not to get pregnant until the follow-up is complete. And whenever after the follow-up is complete, whenever the next pregnancy she tries to conceive, so I would like to explain her to have an early booking ultrasound, because there's a risk of recurrence almost in 1 in 60 to 1 in almost 80 cases. So I would like to explain that.
Okay. So, like, I think we have done with the questions because I still have a time. So, how is a GTD classified as?
Yeah, so GTD, the gestational trophoblastic disease spectrum is classified according to the pre-malignant condition, that is the complete mole and a partial mole. So which is divided according in complete mole, there will be no fetal parts, where in partial mole, there will be a molar pregnancy associated with the fetal parts, and a gestational trophoblastic neoplasia, that are the malignant lesions, which comprises of the choriocarcinoma, the invasive mole, and placental site trophoblastic tumor and epithelioid trophoblastic tumor.
Okay, fine. That's all, Priya. If you want to add anything, which you think.
Yeah. So I want to add regarding contraception also. So previously, IUCD was not recommended in case of an molar pregnancy. Now the recent FSRH guidelines, they comment that all kinds of contraception can be used, and IUCD can be used under consultant decision if the HCG levels are falling. In that case, they can be used.
Are you talking about COCs?
COCs, they can be used, but IUCDs I'm talking about copper
Yeah.
coils. So the FSRH recent recommendation is if the IUCD, the HCG levels are falling, then
Mhm.
the consultant, the senior clinician decides to put an IUCD, they can be put. If the HCG level should fall or come to normal.
Okay. Okay. Thank you, Priya. I think we are still left with almost a minute. That's fine. So I think my feedback for you would be you have covered most of the things. Your history taking was already on justifying mode and also telling about the differential diagnosis. But I didn't hear you talking about allergies, did you?
Allergies, I told Dr. Soumya, I want
You
to
told? Okay, fine. Probably I wrote down because I wasn't very sure. Okay.
yeah.
And I think differential diagnosis you said, although it's a good idea, as you mentioned in the history taking, no, gynecological and non-gynecological, you could put it across. And the rest of the things you covered, even investigations, if you put it like bedside and blood and urine and then probably radiological. And I think I like the fact about the Breaking Bad news. And I think the management was fair enough, section vacation and TD, and you also mentioned about the follow-up. I think that was good one. So probably you can show them the slides.
So here, this is a case of a complete molar pregnancy. So in history taking, it is very important to with the complaints that they have come. So to categorize how is the severity of the vomiting according to the puke score and the vaginal bleeding, how it is. It is a simple spotting or an excessive passage of clots. Regarding the obstetric history, to in the history you can just have a suspicion what she can have either a molar or a twins which can cause hyperemesis, any other medical conditions which can cause hyperemesis like gastrointestinal or renal problems. Blood group and reservation is very important in these cases, especially because if they want to undergo a suction evacuation and if they have any reservations, and also in case if they are Rh negative and non-sensitized, we may need to give them an anti-D. And allergies are very important in every case as a patient, as a safety point. Then what can be the differential diagnosis? So yes, it can be hyperemesis gravidarum or a molar pregnancy or a multiple pregnancy which can cause hyperemesis due to raised STG levels and threatened miscarriage and ectopic because she has come with spotting in pregnancy. Also, there can be hyperemesis. There can be other gastrointestinal and renal problems, liver problems which can cause. So the investigations depend upon that, as Dr. Somya rightly corrected that it should be a bedside investigations in the form of a complete blood count, the urine analysis to rule out any urine infections, and ketones also to look for the severity of the hyperemesis, and blood group and RH typing, and urine electrolytes to look for the any hyponatremia or which can happen in case of hyperemesis, and blood glucose levels also, and ultrasound to rule out any twins and molar pregnancies that can cause hyperemesis. So it's a case of a complete mole which has the snowstorm appearance without any fetal parts, and GTD is classified into the pre-malignant and malignant lesions, which comprises of complete and partial mole in case of pre-malignant, and malignant consists of invasive mole, choriocarcinoma, and placental site trophoblastic tumor, and epithelial trophoblastic tumor. So management depends upon the type of molar pregnancy. So if it's a complete mole, for that, it is as it is the case of a breaking bad news. So patient should be already properly signposted before that. Without suddenly breaking the bad news, they should be given some hint that you don't have any good news for them. And you should be very empathetic, having the soft tone with the patient. You probably call if they have any someone to call, and then break the news. And here we have to tackle her motion, vomiting, and molar pregnancy by doing a suction evacuation. So regarding the preparation of cervix, the guideline recommends can be done immediately prior to the uterine emptying. And regarding oxytocin, so usually not preferred, but can be given when there is life-threatening hemorrhage. So the follow-up for complete mole is very important. So it is for three values which are done weekly and should be normal. So after that, 8 weeks. Uh, After the if they come within 8 weeks normalization, so the follow-up is for 6 months from the date of evacuation. And if they take more than 8 weeks to normalize, so the follow-up is for 6 months from the date of normalization of HCG. For partial mole, once the HCG serial HCG values, weekly HCG values are normal, a follow-up repeat HCG is done after 4 weeks. And if that comes normal, the follow-up is complete. So we have to make sure that the patient doesn't get pregnant and uses some kind of contraception during this follow-up period. And as we know that there is a recurrence of almost 1 in 80, so they should have in next pregnancy an early viability scan to rule out that it's not a molar pregnancy. So the recent recommendation is that the women who have not received any chemotherapy, so they no longer need to have an HCG measured after subsequent pregnancies. And contraception, so all methods can be used. So IUCD, if the values are high, they are not recommended, but if they are falling, so under specialist advice, it can be used. So here a good candidate will take a proper history about the severity of vomiting and also the spotting, and also if there is any family or if there is any previous history of molar pregnancy. for the recurrence, and will rule out any allergies and any Jehovah's Witness cases, and also uh, uh, will categorize for the differential diagnosis that can be. And further management will be according to the differential diagnosis, and once the ultrasound is done, it will be under a suction evacuation, and sending the further follow-up will be under the gestational trophoblastic disease center, where in Ireland it is located in the Cork University. And here it will be a multidisciplinary team and also involving the GP. So proper contraceptive option giving is very important, so that they shouldn't get pregnant during the follow-up period. So explaining them the recurrence rate, and the HCG proper monitoring, having the proper follow-up according to the, is it a complete or a partial mole. So the main purpose of this follow-up is to look for if are they going into the gestational trophoblastic neoplasia cases, because in that case it will be persistent high. So that was for the molar pregnancy. Thank you so much.